Good evening, everyone. Welcome to Cornerstones Best of DDW in IBD 2023 for Australia webinar. I'm happy to introduce tonight Professor Susan Connor and Associate Professor Miles Sparrow, who will be bringing you our Best of DDW program. I'd like to thank our supporter for this activity. Cornerstones receive a generous, unrestricted educational grant from the ANSWER to support this program and truly appreciate their contribution. I will now hand over to Susie, who will begin the webinar. Thank you.
Thank you, everybody, tonight to Cornerstones. And it's a real pleasure for both Miles and I to be able to present this webinar to those people who weren't able to attend the in-person presentations earlier in July. Before we, I'd also like, Miles and I would also like to thank ANSWER as well for their donation, the money, the support that they give to Cornerstones in order for this program to be possible. Before we start the program, Miles and I are just going to quickly remind everybody about the process that we go through as part of the Cornerstones Education Best of DDW program. There's currently 37 IBD faculty across 13 countries, which are made up into 7 teams, and you'll see which are the different sort of subject areas. And as well as fellows, we get assigned to these 7 different key topic areas. Prior to DDW, we're all then sent about 1,000 abstracts from DDW around immune-mediated and IBD gastrointestinal diseases. And then we look at all the abstracts from DDW, and then in each of our groups, we decide which abstracts would be most for us. Then send back to Cornerstones, and they're re-divided up. And then prior to DDW, we have a meeting face-to-face with everybody, and we all decide then who gets what abstracts. And then during DDW, each of our individual teams then goes around and looks at the presentations and the posters, and then decides on our top best of. We have slide presentations, which we then present in a meeting with everybody after DDW. We present the slides and votes on it, and on which are the best presentations and abstracts that we then are going to present. That then goes back to Cornerstones to edit the slides, and they get sent to all of us and then presented around the world. But in terms of Australia and New Zealand, Miles, Richard and I then go through the slide deck again together, and over 3 or 4 hours we then decide which we feel are the best 40 to 45 slides, which we then present to you in the presentations. And tonight we'll be presenting half those slides, and on Thursday night we'll be presenting the other half of those 40 slides. So tonight's webinar will be about an hour, and similarly on Thursday night. In terms of the slide deck, you will receive those emailed to you, as well as Joe mentioned, they can be downloaded as well directly from tonight's webinar. Where these are the faculty, which are from all around the world, apart from Europe, except obviously the UK. And we're particularly indebted to the fellows who really do the lion's share of the work. And this year from Australia, we had Patrick Chan from Liverpool Hospital and Robbie Little from the Alfred. And here's a photograph of all the fellows who here look very happy, and they all made friends, and it's really a wonderful time for all of us together and a great learning opportunity. These are the 7 topic areas that we'll be going through the course of tonight and also on Thursday night. And tonight we'll be specifically covering epidemiology, natural history and prevention of IBD, current emerging therapies and non-biologics, including small molecules, treatment-related adverse events, and then disease-related outcomes. The top 3 take-home messages that I felt from DDW were these. All the data around upadacitinib, which has been shown to be efficacious in Crohn's disease, including achieving hard induction, massive endoscopic response remission, and also clinical healing around fistulas and fissures. Well, certainly some suggestive data that it may be effective in that context. We'll be discussing this tonight. Additionally, surgical strategies in Crohn's rapidly advancing, and tonight we'll be talking about the role of early surgery in isolated Crohn's disease and further data on post-operative occurrence with cone western anastomosis. And on Thursday, we'll be talking about the role of vedolizumab in post-operative prevention. And finally, an Australian study The VIEW study, looking at withdrawal versus continuation of thiopurines and ulcerative colitis in deep remission who are on vedolizumab thiopurine combinations. And also that although thiopurine withdrawal did not affect vedolizumab drug levels, withdrawal did result in increased calprotectin histologic and histoendoscopic activity. And there was a trend to more relapses in withdrawal patients who were prior anti-TNF failures. So they're the 3 take-home messages, and we'll revisit them again as well on Thursday. Now for today's topic. So the first one is epidemiology, natural history and prevention of IBD, and I'd like to encourage all of us to please put questions into the question panel, which we'll address at the end of each section. So we're firstly going to talk about the GEM project, which is a really amazing project. GEM stands for Genetic, Environmental and Microbial Determinants of Crohn's Disease. And this study was started in Canada in 2008, and the first individual was recruited in 2008, and now we've got 15 years of follow-up to date. This was initiated in Canada by Crohn's Colitis Canada after they received a large donation. And they have now got over 5,000 healthy first-degree relatives of individuals who are affected with Crohn's disease. If you look over on the right, the point of this study is to look at individuals who do not have Crohn's disease yet, but are first-degree relatives of people who do have Crohn's disease. And then collecting genetic factors, looking at calprotectin, intestinal permeability by lactose mannitol ratios, diet, and a whole lot of microbial sequencing as well to try and genetic scores prior to patients actually getting Crohn's disease, and then waiting until these first-degree relatives get Crohn's disease, and you can see them when they're diagnosed with Crohn's disease, and then looking back and then seeing what are the features of these people prior to them developing Crohn's disease, and then comparing it to those people who have not yet developed Crohn's disease and trying to understand what the genetic, environmental and microbial determinants of Crohn's disease potentially are. Tonight we're going to be talking about more of the GEM studies. There are multiple studies presented at DDW, and we'll hear about GEM for multiple years to come. The first study on the left, number 1, is looking at exposure to parental Crohn's disease in the perinatal period compared to, so that's people who develop Crohn's disease who are exposed to the parent during the perinatal period, so i.e. in the first year of life versus beyond the first year of life, and then what the risk is compared to in those two groups. And essentially what they found is in the offspring of those patients who were exposed to their parent and developed Crohn's disease in the perinatal period versus after that, they had a higher increased future risk of developing Crohn's disease with an adjusted hazard ratio of nearly 5-fold. What they found is that early life exposure was particularly associated with increased intestinal permeability in this offspring, and also changes in the microbiome in these offspring. So it suggests it's not necessarily just genetics, but there are other environmental exposures that potentially in the early perinatal period that increase the risk of offspring developing Crohn's disease. The other observation in this study was that if the earlier you're exposed to the mother, so the earlier in life you're exposed to the mother, but not the father, the higher risk of developing Crohn's disease. So also some exposure to the maternal factors early in the perinatal period appears to be of particular importance. And I guess this is really no surprise. I'm now going to talk about this third study, and this is looking at patients of people who have developed Crohn's disease and comparing those people that develop Crohn's disease who have more than one first-degree relative with Crohn's disease, so they're multiplex families, versus simplex families where there's only one first-degree relative. And you can see the division. Most people have only one first-degree relative, and about 333 had more than 2 first-degree relatives. They confirmed previous findings that you have about a 3-fold increased risk if you have if you're a multiplex status offspring, compared to only having one first-degree relative with Crohn's disease. So that's been confirmed. We've known that from previous data. What was actually interesting in those multiplex offspring, what was associated with an increased risk of Crohn's disease was in fact a subclinical inflammation shown by elevated calprotectin, and also altered microbiome in these incident cases. And in fact, that the Crohn's disease polygenic risk score, in fact, didn't appear to be associated. So it appears to be not necessarily genetic only factors, but also environmental factors that increase the risk in these incident cases. I'm now going to look at study 4, which is looking at serum metabolites in the pre-diagnosis of Crohn's disease. And what they did was they assessed alterations in the metabolites in the serum in the preclinical phase of Crohn's disease, and then looked at this compared to controls, so 1 to 4, and see if there are any particular metabolites that appeared to be associated with Crohn's disease development. They found 63 metabolites in the serum out of 1,000 identified. And of those metabolites, the ones that seem to have most association were ones associated with gut barrier function and also with inflammation. And interestingly, the metabolite model had a very high area under the curve in terms of predicting those patients that would then go on to develop Crohn's disease. It's actually a higher predicting than the genetic models and also fecal calprotectin. That's really interesting that the metabolites in the serum appear to be suggesting already that there's some changes that they're associated with change in gut barrier function, and what's actually going on in the serum already is giving us a hint of where the pathogenesis of Crohn's disease might be. And then to go on from that, they then looked at those metabolites and then looked at the dietary constituents of those 78 Crohn's disease patients compared to 311 controls, and then looked at the dietary constituents by the food-free questionnaire, which the individuals had also undertaken, and then looked at the metabolites and then saw the association with various food and dietary components. And those dietary components with the highest number of associations with the Crohn's disease associated metabolites were docosahexaenoic acid, which is in monounsaturated fats such as canola oil, alcohol, and aspartame, which is an artificial sweetener. So it's suggesting, like we already think, is that there are dietary components which increase the risk potentially of developing Crohn's disease subsequently. This paper has been published in Nephrology earlier in the year and was presented at DDW this year, and is looking at the anti-integrin autoantibody alpha V beta-6 integrin and demonstrating that it predates ulcerative colitis diagnosis and also associated with adverse outcomes in ulcerative colitis. So alpha V beta-6 integrin has been known to be present in patients with ulcerative colitis with a specificity of about 98%. And so this is why this study was done. Also this is meant to be associated with epithelial barrier function, which is why this study is also being done. So the two aims were to test for the presence of these autoantibodies in the preclinical phase of ulcerative colitis, so prior to ulcerative colitis developing, and then seeing if the titers of these antibodies in the serum were associated with a more severe disease course. The data was taken from 4 studies, firstly from preclinical cohorts, from the PREDICT study, which is a study of men and women who are in the armed forces who then may or may not develop Crohn's disease in the US, and then the GEM cohort, so these are patients who developed ulcerative colitis rather than Crohn's disease. We looked at the clinical phase, and then they looked at 2 inception cohorts subsequently, the COMPASS and the OSCAR studies. So in the PREDICTS and the GEM cohort, so the validation cohort was a GEM cohort, they had in the PREDICTS cohort, they had 82 incident and 82 match controls, and they checked these alpha V beta-6 integrins in serum at diagnosis of ulcerative colitis and 2, 4, and 10 years prior to diagnosis, and they validated the diagnosis, validated these findings in the GEM cohort with 12 UC patients and 49 controls, and they were able to have blood up to 4.2 years prior to the diagnosis. I'm going to take you first down to these results, and if you look over on the right, you can see these findings. So on the left, there's 10 years before diagnosis, 4 years, 2 years, and at diagnosis going across to the right, and the blue is the healthy controls and the ulcerative colitis is in pink. And what they found was that even up to 10 years prior to diagnosis, there were higher levels of alpha V beta-6 antibodies in the serum of patients that then went on to develop Crohn's disease. And this is 12.2% 10 years before diagnosis, and up to half of patients had these autoantibodies in their serum at diagnosis, and this is compared to only 2.7% of controls. And this was able to predict the potential to develop ulcerative colitis with an area under the curve of more than 0.8, and that was consistent across the 10, 4, 2, and at diagnosis, years before diagnosis. So a very high area under the curve. So potentially this autoantibody can be used to predict those who are more likely to develop Crohn's disease, ulcerative colitis, sorry. The other really interesting thing is one of the things we're trying to find is actually predictors for those patients that will do worse, both in ulcerative colitis and Crohn's disease and at diagnosis. And this study found that in those patients that had the higher titers of alpha V beta 6 were more likely to have adverse outcomes, and these were defined as hospitalisation, disease extension, colectomy, systemic steroid use, and biologic therapy. And you can see over on the bottom right-hand corner, associated with outcomes. And the titers, the blue is the lowest titer, and the red is the highest titer. And you can see on the left, the y-axis is the complication-free survival probability, and the higher the titer of the alpha V beta 6 autointegrin in the serum, the more likely patients were to develop complications. So the bottom line here is that the antibodies precede the diagnosis by up to 10 years, and they are also, the higher the titer, the more likely the patients develop adverse ulcerative colitis related outcomes. This is very exciting in terms of findings in ulcerative colitis. And finally, from this group, we're going to look at, there were many studies on dietary factors associated with the risk of IBD and the flare in IBD. The dietary studies are notoriously very hard to undertake. These are two of the more interesting studies. The first one on the left is a one-year study from Miami, and in adult self-identified Hispanics who had IBD in remission. And the primary outcome was a composite outcome of failure, which was an elevated calprotectin plus symptoms. What was interesting about the study was that they actually developed a culturally relevant population-specific diet questionnaire. And then what they did was they looked at using unsupervised machine learning, using a new technique called SID clustering. They then actually clustered the cultural food composition into 4 different clusters based on the frequency of each of the types of food that each of the patients were eating. And they had 4 different clusters, and you can see them down on the graph at the bottom of the panel. And what they found was there were 214 Hispanics, and 33% of they were followed for 1.2 years. 33% had a flare. What they found was in cluster 4, where they had higher intake, up to 4.5 intake of starch vegetables per week, they had a lower rate of biochemical and clinical activity, so a lower rate of flare. So if they had a higher intake of starchy vegetables, they were less likely to have a flare. And in this cluster as well, they had a higher intake of tropical fruits. And so it appears that, again, similar to what we found in other studies, that a higher intake of vegetables and fruit were less likely to, those patients were less likely to develop a flare. So, but as I said, what was particularly unique about this study was the unsupervised machine learning to develop the culturally relevant food consumption clusters, and then to look then at that association with or not with flares. That was a very interesting study. And the study on the right is a study you're going to hear a lot more about, and this is the PREDICT study, which stands for the prognostic effect of environmental factors on Crohn's and colitis. And this is a study going on in the United Kingdom with 49 adult and paediatric centres. And they're looking at diet intake over, and they're doing questionnaires every 2 months, and then looking at what dietary factors associated then with a flare. And a hard flare is basically both symptoms and elevation in calprotectin or CRP, as well as a change in therapy. There were so far there's 2,629 patients have been enrolled. There's about 5.6% flare per year, and this analysis we're going to talk about, which is around dietary, they wanted to make sure the dietary food frequency questionnaires were complete, so there were just over 1,000 patients involved in this study. What they looked at specifically was around habitual meat intake, judged by the food frequency questionnaire, noting that in this food frequency questionnaire, fish is included in meat. And the primary outcome was the time to first hard flare. And what they found was, and you can see it down on the graph there, the Kaplan-Meier curve, the flare-free survival was less likely, flares were less likely to occur if you had a lower meat intake, and divided that up into 4 clusters, with the lowest cluster being in red of 0 to 24.9 grams of protein per day. And just to note, 25 grams of protein is half a chicken breast, and up to 331 proteins per day, which is the blue, and essentially showing that a habitual meat intake was associated with flares in ulcerative colitis, but it was not associated with flares in Crohn's disease. And this was statistically significant between the highest and the lowest quartiles of meat intake in ulcerative colitis. Unfortunately, as I said, there are some differences with studying that we can't work out which particular meat, but there has been dietary evidence already telling us that we shouldn't be eating too much meat, but it really isn't at this stage to say that we shouldn't have any meat. It's just saying that large intakes of meat do increase the risk of ulcerative colitis flares. So that's the end of the first part of the talk. And Miles, have we got many questions?
Yeah, we haven't got any questions yet, Susie, so please I'd encourage everyone to send them through via the chat portal there. I might just make a couple of comments, Susie. I think it's just so exciting, these GEM data. You know, it's 15 years in the making to get to this point, and it's a real credit to Crohn's and Colitis Canada, who've, you know, made this study happen. It just shows how strong this genetic environmental association is. I found the data that the multiplex families, the first degree relatives of them, had more microbiome changes and subclinical inflammation. I found that just fascinating. And then the other comment I'd make on the dietary studies, as you alluded to, it just shows how hard they are to do well. You know, these are really good investigators, but they're sort of flawed studies with a bit of a mixed message. You know, in Maria's study from the Hispanic population, as we'd expect, you know, fruits and vegetables are associated with lower flares, but that actually didn't come out in Charlie Lee's Edinburgh study. You know, they're just so hard to do, and I think we've got to move beyond food frequency questionnaires in some capacity.
I mean, it's interesting. I've actually been involved in the AIM study as a control, and we have to do food frequency questionnaires as well in that study. And I must admit, even as a very fastidious participant, I found it very hard to recollect what I had even like 3 hours ago. So you can see why there's problems with the studies. Even having a very good questionnaire where you actually can quantify exactly how much you've had, obviously it's just really hard to recall it. I mean, hopefully in the future we'll be able to check serum or, you know, other ways, more sophisticated ways of actually working out what people have been eating.
And there was some signals of that in that GEM data, weren't they, went on their metabolomics. But it's great to see that, you know, dietary studies are getting presented at DDW where they historically haven't until the last.
No, exactly. And I also think it was interesting using the machine learning technique, because they actually looked at what people were eating, and then using this unsupervised learning technique actually try to work out how to cluster the dietary intakes. They weren't necessarily saying you can't have any ultra processed food, but only potentially a small amount compared to the larger intake of starchy vegetables, and just clustering it to try and work out the frequency with which people are taking things. But again, as you said, the problem is actually working out how accurate what people are recalling they've actually eaten still remains a problem. Anyway, should we move on? And I'll just transfer.
Do you want to transfer over to me?
I will. There we go.
Okay, well, welcome everybody. It's a real pleasure to be here. Thank you for the attendees. I'm going to be speaking on the emerging therapies, non-biologics, including small molecules. And this has become a really big part of our field now, and a really exciting development of small molecules. So as Susie had mentioned, one of our top 3 was the upadacitinib results in Crohn's disease. We'd seen clinical data before, but what we learned from DDW was that upadacitinib is highly effective at achieving endoscopic, really hard endpoints, and also for fistulae. Just quickly in the trial design, so these programs were UXL and UXceed. The induction studies was 45 milligrams for 12 weeks. Just a couple of comments on that. 45 milligrams is the highest dose of JAK inhibitor that's been trialed for any indication, remembering that it's 30 milligrams as the induction dose in ulcerative colitis, and 12 weeks is 45 milligrams in ulcerative colitis as well, but for a longer period. of 12 weeks in Crohn's disease versus 8 weeks in UC. Then this was a 2-to-1 study. There were the 2 studies here. UXL was in patients with and without biologic failures. They could have just failed conventional therapy. UXCEED was just in biologic failure patients, perhaps a slightly tougher cohort. It was a 2-to-1 randomization of drug to placebo. So we had over 670 patients receive drug, this high dose of 45 milligrams for this long duration of 12 weeks, 2-to-1 versus placebo. There was a steroid taper. Once you've got one induction agent on board, which a JAK inhibitor is, you want to get your steroids off quickly, so they were tapered from 4 weeks appropriately. This was a randomized responder study, such that they were picking winners and randomizing into maintenance only those patients that responded to induction therapy. And then these patients received either 2 doses of upadacitinib, that's 30 or 15 milligrams, or placebo. The outcomes that we're interested in here are the endoscopic outcomes, a hard objective endpoint. So that's endoscopic response, which these days has a fairly classic or fairly consistent definition of a reduction in your SES-CD of 50% or remission between being an SES-CD of less than 4. These were centrally read at the end of induction and maintenance. If we look at these results, and that the top data here are the endoscopic data, we have the induction in green at the left, the maintenance in blue at the right. And what we can see is we've got even as early as 12 weeks, which is early in a Crohn's disease induction study, we're seeing a really nice separation between drug in green and placebo in gray. You can see that the response is endoscopically is less for both response and remission in the biologic failure group versus those without prior biologic failures, but actually so is the placebo response in that cohort is much lower, such that the delta isn't all that difficult. It's around between 30 to 35% for response and 15 to 25% for remission. And this is something we're learning with JAK inhibitors, that whereas there seems to be a bit of a law of diminishing return for multiple biologics, these agents work, although not quite as well, still very well in patients that have been biologic exposed. They're really nice data for induction at the end of 12 weeks. When I look at those, that reminds me of the anti-TNF data that we learnt nearly 20 years ago in Crohn's disease. If we come over to the right and our maintenance data, we can see we've now got 2 doses here, 30 milligrams dark blue, 15 milligrams in light blue. You can see that there is a numerical superiority of the 30 milligram dose over the 15 milligrams for both outcomes of response and remission, again, with higher response rates in the naive versus experienced patients, but still working in those that are experienced. All of these versus placebo, both doses were highly statistically significant. So this is a really hard endpoint with a new therapy that's looking highly effective. This would be our first small molecule that that is registered for use in Australia, and we hope will be reimbursed for Crohn's disease soon. We've obviously had access to this agent for ulcerative colitis since the 1st of July. We look at the bottom, and this is the extended induction data, and the message here is don't give up too early. I think we could say this with all of our therapies, but we've perhaps learned from post-hoc analyses from registration studies of small molecules of the importance of giving time where possible. And this is a sub-analysis from UXL and UXCEED of 122 patients that hadn't responded by week 12, which is where the primary endpoint, and they received a further, I'll go back here, a further 12 weeks of therapy. This was at a lower dose of 30 milligrams, so they didn't get 24 weeks at 45, they got 12 at 45 and 12 at 30. And you can see that looking at the orange graph at the bottom left, we're seeing at week 24, i.e. after 6 months, you've captured another 50% of patients, i.e. these were patients not responding who were, this is just for clinical response, 52%. But then if we look over to 12 months at week 52, we're seeing the majority of these are maintaining this response out to a year. So again, the message here is don't give up too early on JAK inhibitors and S1Ps and other small molecules if you have time. The other really encouraging data from that upadacitinib in Crohn's disease were the fistulae data. We can see here this is a sub-analysis from this same trial data set of 143 patients with fistulas, and they also looked at at fissures in 54 patients. Fissures, have been excluded from clinical trials. As we all know in clinical practice, fissures make patients miserable and significantly impair their quality of life. It's great that they were included as an endpoint. The majority of these 124 were perianal fistulas. There were some enterocutaneous, a really nasty phenotype. The outcomes here were clinical. What really matters, especially with a perianal fistula, is what's happened radiologically, and that's what Susie and John's proactive study will be hopefully showing and demonstrating for us proactively with some TDM. But here the outcomes were fistula activity, the usual endpoints that are used for the external closure of fistula openings, complete resolution of drainage, or a greater than 50% resolution of drainage. If we look again, the induction data is in orange on the left. So this is early. This is a tough phenotype fistulae. We're looking at week 12. We're seeing in terms of external closure of fistula orifices in 20% of patients at week 12, no drainage in just under 50%, and more than 50% resolution of drainage in 50%. I think, again, that result really reminds me of anti-TNF-like data. If we see at the bottom in left in figure D, we can see that resolution of fissures was in about 50% of patients as well, which is encouraging. Figure E just shows that the patients whose fistula responded, their luminal disease responded as well. If we look at maintenance with a lower dose, and we do get a bit of a drop-off in the fistula response out at a year for both doses. Interestingly, there's not a dose response here. I can't really explain why the results for 15 milligrams are better than 30, but it's probably just the sample size. If you see here, we are down to sort of 10 to 20 patients per group. But again, there were nice maintenance of fissure response as well. These are highly encouraging data, and we all know how hard this phenotype is to treat. The issue with JAK inhibitors, though, isn't efficacy. I think we're all convinced of the potency of these agents. It really is safety. And so upadacitinib, which is a JAK1 selective JAK inhibitor, we hope and anticipate that this will be safer than a non-selective JAK inhibitor such as tofacitinib. However, we don't yet have a lot of the real-world data that we've got with Xeljanz, and so we're watching this space with interest. We're also watching this space with interest in the knowledge of the very high induction dose that's used for upadacitinib. As with most JAK inhibitors and small molecules, the development program moves fastest in ulcerative colitis. So we've got the most data for safety from the ulcerative colitis registration studies, which were UAchieve and UAccomplish for upadacitinib in ulcerative colitis. And their maintenance study here, their long-term extension study was UActivate. So this analysis is in over 1,300 patients, a typical young patient cohort with ulcerative colitis, and it's the question that they're asking is, how are our patients going in the longer term in terms of safety with this agent? So 1,300 patients here with follow-up. So there were treatment emergent adverse events, as we'd expect in this clinical trial. We're looking at outcomes out to, I believe it's 12 months that we're looking at here, because it's the maintenance doses, 15 and 30 milligrams. So there were more serious infections, zoster, which we know is a JAK signal, neutropenia. You do hit a little bit of JAK2 with UPA, although it's mainly JAK1 selective, abnormal LFTs and CK. But what we're really concerned about with JAK inhibitors were these safety signals that were shown with tofacitinib in rheumatological populations via oral surveillance, and pleasingly shown here on the right, within the red box at the bottom here, there was no increased signal of malignancies, MACE, and thromboembolism with this longer-term upadacitinib use to date from these registration programs. So these are encouraging data. It's early days. We've got to watch this space with interest, but to date, we're not seeing any of these oral surveillance signals as yet. We've got more therapies. We're learning how to position and use them. What about when, again, speaking about upadacitinib in ulcerative colitis data here, what about how does this therapy work when other advanced therapies has failed? Remembering advanced therapies is obviously the term we use now that combines biologics and newer small molecules. Just two studies, lesser quality studies, one retrospective, one a small prospective series, but an interesting message. So the first study was from 11 cohort centers in the US, just 100 patients. They'd been exposed to multiple advanced therapies, just 13% of them had actually failed 4 therapies. If we look at these results down the bottom, remembering these are ulcerative colitis data in this study, and the question we're asking is, does upadacitinib work when they've failed multiple advanced therapies? You can see clinically at week 16, if we look in those patients exposed to 1 or 2 advanced therapies and had failed them, upadacitinib worked in 3/4 of patients, and even 80% who'd failed 3 or 4 advanced therapies, lower but still highly acceptable rates for endoscopic outcomes. I think the most interesting one is study 2 down the bottom. This is from the University of Chicago and David Rubin's clinic. This is in patients who just failed TOFA. It's actually a mixed cohort it's small, it's early days, 26 patients, 3/4 of them ulcerative colitis, 1/4 who'd Crohn's disease. So this is patients that have failed 1 JAK inhibitor, asking the question, does another, i.e. the selective inhibitor upadacitinib, work? You can see it's really early days. Even though we've got 26 patients, the results are only out to week 8, so at the end of induction, and the numbers are really small here. I'd caution you to be aware of that, sort of 7 and 8 patients, but the vast majority of patients, between 80 and 100%, are responding. And I presume that that is reflective of this very high dose of 45 milligrams of upadacitinib that is registered for use in inflammatory bowel disease. So these are highly encouraging data. What about the scenario of acute severe colitis? You know, I always think that this is really the life-threatening medical condition of the IBDologist. This has been the domain of infliximab and cyclosporin, increasingly infliximab. We're really looking forward to the results of another PREDICT study other than the one Susie presented earlier, which is the Pete de Cruz's Austin study on this comparing infliximab doses. But this is a study from Michigan, a center that's had a strong interest in acute severe colitis. And Peter Higgins was one of the leaders in suggesting that we should use very high doses of infliximab in this population, especially in those with a high CRP to albumin ratio. What his group's looking at here is, what about upadacitinib for acute severe colitis, so an oral small molecule in our inpatients who'd failed IV steroids. Obviously a very convenient option. We've got some small case series of success for tofacitinib in this. This is so the dose here is a high dose at 60 milligrams a day as a split dose. These are patients that are acute severe inpatients failing steroids. Numbers are small, but results are encouraging. 23 patients. Interestingly, only 3/4 of them had failed a prior advanced therapy. So for some reason, in 1/4 of patients, they went straight to upadacitinib. A couple had failed tofacitinib earlier. This is really recent data with a very short follow-up of not even just under 4 months, but the steroid-free remission rates out to that point were 80%. I caution everyone, this is off-label, as is any JAK inhibitor for acute severe colitis at this stage, but the data are mounting here and they're largely encouraging. There's an Australian publication from Rob Gilmore from Jake and Yoon's group that was published in JCC the week before last of upadacitinib in acute severe colitis, a small case series of 6 with a very high response rate as well. There were some side effects. There was a clot, but it was in a post-op patient. There were some infections. Let's watch this space, but with a lot of interest in this tough phenotype of our sickest inpatients. Moving away from upadacitinib now to some further comparative effectiveness data. Again, with more therapies, we're learning how to position them. Where a lot of these data have emerged from real-world series is in the cohort of patients in ulcerative colitis who failed their first biologic, and it's usually an anti-TNF. For some reason, in some jurisdictions overseas, for economic or other reasons, that an anti-TNF has to be used first in ulcerative colitis. I think for many of us in Australia, we'd be using vedolizumab as our first-line biologic in UC. One of the people who've led this work is Anthony Buisson from France. He's previously published that in UC patients failing an anti-TNF, perhaps going to a small molecule with TOFA rather than Vedo is a better option, especially if patients have failed the multiple prior biologics. The question he asked here in this multi-center study, it's retrospective, and it's just an induction study out to week 16, is your UC patients failed an anti-TNF. what about TOFA versus ustekinumab, which again is one of the 3 new small molecules that we small advanced therapies rather that we've had since the 1st of July for UC. So this is a French retrospective multi-center study comparing those 2 outcomes with the primary endpoint steroid-free remission at week 16, the usual secondary endpoints. You can see that patients received 8 weekly ustekinumab. There was the option at clinician discretion to receive 4 weekly. Patients received 10 BD induction of TOFA. 40% of them after week 8 stayed on this high dose, as I think is very common in clinical practice. Nice size of sample size, just under 300 patients, relatively evenly matched. So primary endpoint steroid-free remission at week 16, there was actually no difference between tofacitinib or ustekinumab in these anti-TNF failures. There were no factors that independently were associated with whether tofacitinib did or didn't work when they did their multi-factor, multivariate analysis, but there were for ustekinumab. And ustekinumab, as the second biologic in these patients, was less likely to work if patients had been a primary failure to an anti-TNF or if they'd been a failure of 3 or more biologics. So I think maybe the message here is that whilst overall the comparative effectiveness was similar between TOFA and ustekinumab, where we should start thinking of using JAK inhibitors is as our second line and in some patients first line therapies, because it does seem that there is not as much of a law of diminishing return after patients have failed a biologic, especially as primary failure with a small molecule as there is with another biologic class. Obviously, retrospective data with the caveats and confounders and flaws of those studies, but useful for informing our clinical practice. Let's turn now to ozanimod. Ozanimod is the third of these agents that we have reimbursed on July 1 for use in ulcerative colitis. The registration program was True North, which was an induction and maintenance and open label study. Ozanimod is an S1P modulator. It effectively traps lymphocytes in lymphoid tissue, including lymph nodes. It acts via S1P receptors 1 and 5. This has some novel side effects. It's been associated with cardiotoxicity and bradycardia and conduction delay and macular edema. Those side effects are important but rare, usually in patients with predisposing conditions to them. These are the open labeled extension safety data, and I do think these are really useful to scrutinise if we have a new therapy in Australia. You really want to see how are those patients going that have been on the drug for longest, and that is the open label extensions of these. So that the True North study was a year. Then these patients, the open label study was a further 94 weeks. So that's effectively 3 years of therapy. So what we're looking here is the safety data out to, it was a mean patient exposure of 2.7 years. So if you're looking at going across the top here in these circles, starting at the top left with the orange, treatment emergent adverse events, as they will be in any clinical study, were common, and 82% of patients got a side effect. They always do, that's always about that 70 to 80% rate in a clinical trial, but most were mild. Serious adverse events, treatment emergent adverse events, 18%, adverse events leading to discontinuation, 7%. So the most common side effects were lymphopenia, which we'll go into a little detail, anemia and nasopharyngitis. That's nearly always in the top 3 for an IBD adverse event, nasopharyngitis. And whilst there were 3 cases of bradycardia, 2 cases of macular edema, which mainly occurs in diabetic patients or those with pre-existing eye disease, no patients had to discontinue from those side effects, which is encouraging. If we look at the lymphopenia, and we think mechanistically this is what happens with this drug by its mechanism of action, the rates of lymphopenia are common and it's quite significant. Nearly 60% of patients had a lymphocyte count that at some point in the trial got down to less than 0.5. 8% had a lymphocyte count down to less than 0.2. Thankfully, however, this lymphopenia doesn't seem to associate with infection risk, which is pleasing. Interestingly, perhaps somewhat disappointingly, it also doesn't seem to associate with efficacy. So we can't use it as a marker of whether the drug's working or not. So I think these are largely encouraging data for the S1P modulator ozanimod. As a really big generalization, a JAK's going to be more potent, but with a slightly higher toxicity profile to an S1P modulator, which are slightly less potent, but slightly safer, as a big generalization there. One of the other things that we've learnt from ozanimod is, like other small molecules, sometimes patients need longer to work. The induction endpoint from True North was actually at week 10. What these data show is that if you give the patients an extended induction and they do respond, the durability of that response is good. And also, if patients stop and start a small molecule and respond again, that durability is good. So in a little bit of detail here, there was, of the overall trial program, which from memory was about 800 or 900 patients, there were 226 who hadn't responded by week 10, and they were given a further 10 weeks of induction therapy via the open label extension. A high proportion, about 50% of those patients responded, majority of them actually by week 5. But then what we want to know here is, how do those patients go out to 2 years of open label therapy, i.e. coming up to between 2 and 3 years of therapy overall. So what we've got here at the top right are the hard endpoints, endoscopy and histology. Histology was a pre-specified endpoint in this trial, mucosal healing, which was the combination of those two endpoints. You can see the rates of the durability of this response in the delayed responders was high. It was sort of, in terms of endoscopic improvement, it was almost 50% of patients 2 years later. Similar histologic outcomes. Their responses are always going to be higher in the observed cases versus the non-responder imputation, which assumes if patients fall out for whatever reason, they're failures. The other thing that we learned here is that within this clinical trial, patients could be re-randomized to placebo during maintenance. If they flared, they could get drug again. Those patients responded, and if you can see here, the 3 figures at the bottom down there are the outcomes of those patients out to 2 years, and they had a really nice maintenance of response of, again, the 50 to 60% mark at 2 years. You know, it does seem that, obviously we know immunogenicity is not an issue with small molecules. These are a therapy that we can stop and start if we want to, which is something that'll be popular with our patients. So look, that's the end of my small molecules session. Have we got any questions, Susie?
Yes, we've got one question. It's actually related to diet. So I might answer that, and it comes from, Animesh Mishra. Thank you for the question. Which of our IBD patients should we be advising to minimise their meat intake? All UC patients, high risk UC patients, what about Crohn's patients? Well, the PREDICT study, they didn't show the association with meat intake, and to be fit in the ulcerative colitis patients, they showed it was the highest quartile. So we're talking like very large amounts of meat intake versus 25 grams of protein a day, which is about half a chicken breast. I think we actually did discuss this in the Adelaide meeting with the 5 dietitians that work for Rob Wright and Sam Costello. And essentially, the sort of take-home message is that everybody with IBD probably should be minimising their meat intake. But essentially, at the moment, there's not evidence that you should stop it altogether. But essentially, the best thing to do is to continue to follow the Australian dietary guidelines, the NHMRC guidelines, which are nicely discussed in the gastroenterology guidelines. So for patients, essentially, the advice continues to be what the Australian guidelines are for IBD, and also for diet intake generally across the population. So please look at the diet handout that's on the Gastro Society website, fairly available for all patients and clinicians. And that's the latest from the dietitian group from Adelaide. There's no other questions here, but please, everyone, do ask any questions. No question is stupid. A couple of comments I just wanted to make. I thought in terms of the UPA versus TOFA data in the anti-TNF failures, I just thought it was also interesting that, in fact, in that induction study, half the patients actually, on ustekinumab continued on 4 weekly, and in TOFA, 41% continued on 10 milligrams BD. So quite a proportion of both sets of patients continued on higher dosing.
Susie, I think that's a really valid comment, and I think that's the reality of our clinical practice, isn't it? That, 35 to 40% of our IBD clinic patients at the Alfred, when we ordered it, are on a higher dose than registration dosing, and it's just such a logistic challenge to get it, isn't it, for all of us? But I think that'd be probably reflective of our practice here, but it's a very valid point.
And just the other point with the acute severe UC, and obviously that's an off-label indication at the moment, but actually 75% of patients had previously failed advanced therapies, not necessarily only anti-TNF agents in that group. So they're quite a hard group to treat.
It surprises me that they went to UPA in 25% of patients who hadn't failed an advanced therapy already. I mean, it's highly experimental. There's obviously confidence with it, but yeah, no, that
I didn't actually realise that 25% hadn't actually failed anything. So that's right. Yeah, I didn't realise.
And look, it must what Susie said there. Look, you know, the appeal of using a once-a-day tablet for our sickest cohort of acute severe colitis practically is great, but you know, we're a long way from that being considered standard of care, and you know, we need to. I think that's a really important disclosure that that's off-label. And
yeah, no, exactly. And I think we should still be going with the tried and true treatment. And obviously, as you mentioned, predict UC, just how we treat patients optimally will be very helpful once we get those results out from Pete's group.
Yeah, absolutely. But you know, a shout out again to Rob Gilmore and his paper that came out in JC week before last. I'm going to, Susie, I'm going to hand back to you as presenter.
Okay, fantastic. Look, thank you for that, and I'll get my slide going. So now we're going to talk about, sorry, just going to get out of there, treatment-related adverse events, safety and vaccines. So the first study is looking at, we know there's been lots of cohort studies showing that preoperative nutritional optimization reduces post-operative risks. And so this study was a meta-analysis trying to have a better understanding using meta-analysis of the role of preoperative exclusive nutrition before any intestinal Crohn's disease surgery. And what they showed ultimately was that there was an association with a reduced infection risk. So what they did was they looked at all studies. There were 714 studies that were screened for preoperative exclusive enteral nutrition, but they only included 14 studies because they had to have exclusive enteral nutrition compared with a control group of no exclusive enteral nutrition. So ultimately, the meta-analyses with the 14 studies included 830 patients who had EEN and 722 controls. And with the meta-analysis, what they found is that there was a significant reduction in skin and wound infection if patients were given preoperative exclusive enteral nutrition with a 1.8-fold reduction, and as well as that, there was a reduction in intra-abdominal septic complication with a 2.2-fold reduction if compared to patients not getting exclusive enteral nutrition. So a strong argument for all patients with Crohn's disease to get exclusive enteral nutrition to reduce the rate of intra-abdominal septic complications and skin and wound infections. They didn't find any difference in the duration of surgery, length of bowel resection or surgical blood loss, but I think just with infection risk alone, there's a strong indication. We know we should be giving preoperative nutrition for all our patients. This study doesn't tell us whether we should be using EEN versus, for example, other supplements specifically, but it certainly gives a strong case for EEN versus no EEN. The next study is a Danish study. It's a nationwide cohort studies of adults who were diagnosed with IBD, so diagnosed with IBD between 1995 and 2021, and looking at the question of, is tramadol better than standard opioids? We know in terms of the usual KPIs, infection, bowel obstruction, surgery, mortality, we know that we don't like using opioids in IBD, and it's associated with severe infections and mortality. We don't know if tramadol has the same complications. So this study was trying to compare the two. They defined initial users as patients who had their first prescription of tramadol or traditional opioids after their diagnosis with a 90-day follow-up, and persistent users as having 3 consecutive prescriptions of tramadol or opioids within the first 365 days of diagnosis of IBD. And the outcomes they looked at were infection, bowel obstruction, IBD surgery, mortality. If you look over on the right, I found actually a staggering number of people had used both. There were over 18,000 patients that had tramadol with a mean follow-up of 4.4 years, and similar numbers with traditional opioids after their IBD diagnosis. In terms of persistent users, it was around 7,000 for tramadol and 8,000 patients for opioids. So actually, large numbers of patients. And interestingly, more patients with UC were using opioids versus Crohn's disease. The take-home message from this study was that those patients who were given tramadol rather than traditional opioids had a lower risk of infection, severe infection, bowel obstruction, and mortality, but no change in IBD-related surgery. And that was both in initial users and also in persistent users. It doesn't tell us, so it's better to use tramadol rather than opioids. But again, I think the bottom line also was that ideally we should be avoiding all opioids, including tramadol. But if we have to use something, to try to use tramadol versus traditional opioids. This study is looking at the NUD15, TPMT, and HLA variants in IBD patients, and looking at the thiopurine-related associated adverse drug reactions. We know that TPMT and NUD15 are both associated with leukopenia, and we also know that the HLA-DQA1 and HLA-DRB variant is associated with pancreatitis, and this was published in APT in 2017. So we already know those. So what the aim of this study was to actually look at, to confirm those genetic associations with thiopurine-related adverse events, and also see if there are any other side effects. So it was a retrospective single-centered chart review of both adult and pediatric IBD patients who'd been exposed to thiopurines from 2005 to 2022. They all were immunochipped and also looked at their ancestry. There were 2,500 patients who had thiopurine exposure, and the take-home messages are over on the right. Now you'll see in the table on the right that TPMT was not associated with hepatotoxicity or leukopenia, but the reason for that was because when this study was carried out, it was already known that TPMT variants were associated with that. So many patients were not given thiopurines in either the dose was adjusted according to the TPMT variant. So the explanation as to why that wasn't seen here was because dosing adjustment was already being made. In terms of the other findings, so just another point to make is that 32.6% of patients who used a thiopurine had any adverse event. So that's an important figure to also note. That in terms of the other associations, the association with NUD15 and leukopenia was confirmed in this study, and also the association with HLA, DQA1 and DRB1 and its associated with pancreatitis was again confirmed. The new findings was that NUD15 was also associated with an increased risk of pancreatitis and also flu-like symptoms. You can see that over on the table on the right. So I think also confirming that we do need to check NUD15 variants prior to initiating thiopurines. And the other thing that actually came home to me after reading this study, I went back and looked back at the literature on HLA, DQA1 and DRB1, is also to actually check for those. Also in people saying, we can discuss this, Miles, it's saying thiopurines, because although the incidence of pancreatitis is low, if someone is homozygous, I mean overall, but if you are homozygous, you have a 15% chance of getting pancreatitis. Anyway, we can discuss that further in a minute, but essentially the other point to make in this study was also which patients particularly who are the ancestry of those patients who have NUD15 variants. And if you look down the lower part of the slide, Africans only ancestry only 0.7% had the NUD15 variants, and Europeans 2.5%. But then in the East Asian ancestry and the South Asian ancestry, which is obviously very relevant for our population, a third in East Asian ancestry and 13% of South Asian ancestry had the NUD15 variants, and also in Latinos, 21% had any NUD15 variant. So important for all of us to remember to check NUD15 variant now that prior to starting thiopurines, and that's obviously available now both publicly and privately through Sonic. Through public hospitals, and also through Sonic privately. Miles, do we have any questions?
We don't yet, Susie, but please send in your questions, everyone, and just a couple of comments on that, Susie. Yeah, I think the message with that NUDT 15 is we should check it in the same way that we check TPMT. It's of vital importance in Asian populations, but it's not unimportant in Caucasian populations as well. And as you said, Susie, it's now available in through public and private labs, which is great. I must admit, Susie, I'm not up to speed on the HLA and pancreatitis
that's interesting. I looked back at the study that was done. I mean, it essentially, they're very small numbers. They looked at 373 patients throughout who started thiopurines. 360 had no pancreatitis, 13 developed pancreatitis, and I can't remember the details of the exact population, but I remember single or multi-center study, I can't remember, but essentially in patients that were homozygous, 15, so there's only 13 out of 373, so low rates. So we're in terms of, say, what that's about sort of 2% basically, develop pancreatitis, which is similar to what we know, right, in terms of rates of pancreatitis. But if you actually were homozygous for HLA-DQA1 and DRB1, you actually had a 15% chance of getting pancreatitis. So in that algorithm, they were suggesting if you were homozygous to not actually give a thiopurine. And that paper was published in APT in 2017. And we could certainly discuss it. Just made me food for thought to think maybe we should be thinking about it. It's available to test. I think it's actually Medicare rebatable as well, because obviously it's done for celiac disease. It can be debated. I really only thought about that today when I was re-looking at it.
Is this the same test that we ask for when we ask for a celiac genetic test?
I think it is. Right. Yes. Well, I'm going to check it up. What I might do actually is ring Sonic, and then we can communicate that with the webinar participants after I've looked into it when we send the email, probably not tomorrow, but the one later in the week. Just to communicate.
Great. Thanks, Susie.
Yeah.
And the other thing that I took from what you presented then, Susie, is with the preoperative EEN. I just think it's like, what's to lose? We've got to do
totally.
it, and, we're lucky, most of us who work in bigger centres, that we've got great dietitians there who are, and it's just, that one's just a no-brainer now. There's no downside.
No, exactly. And I think even if you're in a private setting, you can certainly get local dietitians, in the bigger centres to help with providing EEN for 2 weeks preoperatively if possible. And the other option is, if you can't get EEN, is to give, I think it's 2 supplements a day, but that's part of the surgical guidelines anyway, just to speak to your IBD surgeon about that, because I think definitely preoperative nutrition is now really a no-brainer, at least in the 2 weeks preoperatively. Yep. There's nothing to lose. Yeah. Okay, so we'll now talk about disease-related outcomes. We keep going, Miles?
Yeah, I think so.
In the interest of time?
Yeah,
okay. Yep. Just over. So we'll just keep going. We've got, I think, 5 more slides to go. This one is the chorus, IBD chorus, which is, I love this work that Corey Siegel and Gil Melmoth are doing in the States. It's really a learning health system. It's really, they're involving, they have multiple sites, so 38 sites in this particular study that were involved over 1 year. And what I was looking at is, after the STRIDE 2 guidelines were released, actually looking at treat to target, which is TTT, and looking at these, and the study was over a year, all 38 sites, all the clinicians in each of these sites were just asked to think about asking for these 3 questions when they were seeing their patients, and these 3 treat to target questions. And they get a score of 1, 2, or 3, depending on whether or not they did ask these questions. Was treated to target discussed? Was objective assessment for inflammation performed? And is there an intention to change treatment if the target is not being reached? And basically, they then every month they do this sort of. They gave each site. I'm not quite sure how they worked out. They didn't say in the abstract how they worked out if the clinicians had actually done these 3 things. That they taped the consultations, if it was self-reporting. But after each month, each site would get a report card. And also they had a number of sessions. They have a monthly session with it where everyone can participate and talk and have learning sessions. And everybody participates in 2 learning sessions as well over the year. So it's a collaborative approach. And what they found was that after a year, going the average, the 23% of that, there was about over 4,000 clinical consultations during the year. The number of the percentage of patients were actually getting the question asked in the treat to target questions being asked went from 23% up to nearly half of consultations. So that improved over the year. And then what they looked at is they looked at 5 sites where they did have an improvement in implementation of treat to target versus sites without improvement in the treat to target questions. And they found, if you look down the bottom right, that those centres where they did have an improvement in treat to target, there was a trend to improved outcomes in their patients with improved rates of endoscopic remission and steroid-free clinical remission. And I like this because it's around a quality improvement initiative to try and improve practice and collaborative learning. And certainly it appears that there's a trend towards changing patient outcomes with changing clinician practice. So I really like that audit and feedback loop. Yeah, so applauding to Corey Siegel and Siddharth Singh and Gil Melmer to continue this work. This is looking at ileocecal resection. We all know the lyric initial data that comparing resection of 40 centimetres or less of ileal Crohn's disease versus starting ATNF at diagnosis, and that there was no difference in outcomes of which was quality of life at 1 year post-operatively, but also that the 5-year outcomes of lyric showed that in those patients that had a resection, only 26% of patients required an ATNF at 5 years post-operatively, and 42% of patients didn't need any new additional therapy, although 48% of those were on immunomodulators. So that's the lyric data, really showing very favourable outcomes for upfront ileal resection in patients who have isolated ileal disease. So this was looking at using the Danish nationwide registry to actually look at outcomes of patients who had isolated ileal or ileocecal Crohn's disease at diagnosis that either underwent an ileocecal resection or received ATNF upfront as their index treatment between 1 month and 1 year after their diagnosis. There were similar numbers, as you can see. The primary outcome was a composite outcome of one or more of the following: Crohn's disease-related hospitalisation, perianal diagnosis, corticosteroids, or Crohn's disease-related surgery. And what they found, the data actually does mirror the lyric data, was that with patients who had an ileoclonic resection, the adverse long-term outcomes were 33% lower compared to those who were started on upfront ATNF therapy. And in fact, the adjusted hazard ratio of an ileoclonic resection compared to ATNF for the composite outcome was 0.67, so significantly different. That's shown in the proportion of composite outcome, the Kaplan-Meier curve on the left. And also mirroring or similar results to the lyric study was that with an ileoclonic resection, approximately half of patients were on no treatment at 5 years of follow-up. So it has very similar data to lyric. And also in terms of the outcomes on the right there, in terms of individual outcomes, patients who had an upfront ileoclonic resection had a lower rates of systemic corticosteroid use and Crohn's disease-related surgery, but no difference in hospitalisation or perianal Crohn's disease. So in concordance with lyric, it does suggest that ileocecal resection could be first-line therapy in patients who've got isolated ileal and ileocecal inflammatory Crohn's disease. The next study is the longer-term outcomes of the Cone-OS anastomosis post-operative recurrence study, which was initially published in the Annals of Surgery with the 6-month outcomes in 2020. And what this is, a randomised controlled trial. It is a single centre, non-blinded randomised controlled trial, which is a weakness, essentially comparing the Cone-OS anastomosis, which is a hand-sewn anti-mesenteric functional end-to-end anastomosis. And the photograph of the Cone-OS anastomosis is shown on the left, and they compared this to a side-to-side anastomosis, which you can see on the very far right of the diagrams. And they had 119 patients post-op after comparing 51 patients who had a Cone-OS anastomosis versus 68 who had a side-to-side anastomosis. And the primary outcome was endoscopic recurrence, which is classified as a Root-Gert score of I2 or more at 6 months, and surgical recurrence at 5 years at 60 months. And the 43-month data is here, but the data actually is the same for 54 months, which is when the abstract was presented. But essentially, in terms of endoscopic recurrence, there was statistically significant, or 33% of patients with a cone-of-West anastomosis compared to 75% of conventional anastomosis, side-to-side anastomosis had post-operative endoscopic recurrence at 6 months, so highly significant. That being said, it's actually a very high rate, 75% of endoscopic recurrence at 6 months. So I am concerned that maybe that was overcalled. That being said, the surgical recurrence rate, which I think is a more objective marker, conventional anastomosis had a higher rate at 8.8% compared to cone-of-West anastomosis out actually to 54 months. And on multivariate analysis, cone-of-West anastomosis was the only variable associated with Crohn's disease recurrence. As I said, there are weaknesses with this study in that it was unblinded, so you could tell the patient had a side-to-side versus cone-of-West anastomosis. It was single centre, but the results are as they are, and hopefully with the Australian ileocolonic resection retrospective study we're doing, which we've got much larger numbers, we may be able to get more data on this, and I think there are also plans to randomise and look more closely at cone-of-West anastomosis with our surgical colleagues. This is the last abstract for tonight, and it's looking at rates of cancer. This is a population level administrative data set from Ontario and Canada, looking at people with IBD from 2002 to 2017, which are age and sex matched to non-IBD individuals, and they were followed for the development of cancer up until 2020, and that was identified through the Ontario Cancer Registry. And they looked at the annual cancer incident rates, which were compared to matched with the age and sex standardised rates to the July 2015 Ontario IBD population. They looked also at the average annual percentage change in cancer rates from 2017 to 2020. And the key findings are in the graphs, in the Kaplan-Meier curves down in the middle of the slides. And that is that there's a rising incidence rate of small bowel cancer over time, non-Hodgkin's lymphoma, biliary tract cancer, and not reflected here also lung cancer in IBD patients compared to controls. So that seems to have risen over the past 25 years. The rates of colorectal cancer have reduced. They are the findings. And so that's interesting findings of whether it's related to more use of immunomodulators or not. It's not clear. These are the findings as they are, and I think we don't, what the causation of that is, we don't know, whether it's also increasing age over time, but obviously they were age and sex matched. So just understanding that these rates are increasing in IBD patients, and just to be aware of that. So that's the end of the slide presentation for tonight. Miles, any other questions?
Great job, Susie, as always. There is a question that's come in from Gabrielle Walk. Thanks, Gabrielle. Susie, if you don't mind, I might grab this one. It's related to UPA and acute severe C. The question is, for upadacitinib and acute severe colitis, what did they do with steroid weaning? Do you think there is the potential for use of JAKs as a steroid minimising agent for flares in place of steroids, given there's no immunogenicity? There was some buzz about this at ECHO. Gabrielle, it's a really good point. For the Michigan series, they did rapidly wean steroids, but I don't know what they defined as rapid. But, you don't need 2 induction agents on board, so they did get them off quickly. Yeah, there has been talk, can we use JAKs instead of steroids, as an alternate small molecule induction agent? I mean, I think just our reality is with cost, it's not going to be possible for us, but I think in theory, it's a very valid option, whilst we're, watching and cognizant of, adverse events with JAKs, nothing's got more toxicity than corticosteroids. I think it will largely be an economic reason that we can't do that, but in theory, there's certainly, it's a valid option. But if you have a patient with who for whatever reason is receiving off-label JAK inhibitor of either type for acute severe colitis, yeah, you want to get steroids off really quickly, really quickly, maybe within 2 weeks, sort of thing, coming from IV to off in 2 weeks would be my best guesstimate.
The question from Leanne Tan, thank you very much, was in the study showing increased cancer in IBD patients, is there a comparison between patients with active inflammation versus those with endoscopic remission? No, they didn't look specifically at that. They were looking at just across all IBD patients. But the inference is, it's interesting that the colorectal cancer rates are going down, suggesting that control of active inflammation is reducing those rates. In the questions that came afterwards, there was a number of questions around potentially, as I said, immunomodulators and that. So I guess the answer is no. They didn't specifically look at that. But one of the other findings, as I said, was the colorectal cancer rate did reduce, suggesting potentially that inflammation is reduced. That's what I can say based on the data we were given at DW, and I was actually at that talk.
Susie, can I just make a comment? That the data, Manasi Agrawal's data on early surgery as an alternative to an anti-TNF, they're pretty compelling, aren't they? And they're pretty consistent with Lyric. I mean, Lyric was an RCT. This is just an observational study. I think we've got to be, observational studies have confounders that you can't control for all of them. But just, how is your threshold for early surgery and ileocecal Crohn's disease getting lower? Mine is, but I'm starting to think it should be getting even lower again with these data.
No, it is. I mean, I think we need to have the discussions with patients about it. I mean, those data from the long-term Lyric data, and then just, now we've got this. I know it's retrospective, but it's interesting how similar the figures are.
Yeah.
I think we actually need to be having these discussions with patients actually openly at the beginning.
Yeah, I'm not sure.
Because there's a fear around surgery. I mean, I think the quality of life is different year between the two groups. Yeah. So people worry about the side effects from bile salt-related diarrhea, et cetera, but the quality of life was the same.
Yeah. So, I don't know what that in Manasi. So Manasi Agrawal's paper that Susie presented has just come out online in Gastro as well. I haven't had a chance to read it yet, and I don't know whether they had a definition of the length of ileal disease. I was always quite surprised in Lyric that they could actually have up to 40 centimetres of ileitis that they defined as short segment and for surgery. That to me seemed a long extent, but I don't know what it was in Manasi's study.
No, so we'll have to look at that. Right, great. We'll have to look at that in Gastro so everyone can read that paper, because they didn't talk about it in the presentation what the length was.
Yep.
Yeah. Okay, I think
just nearly 20 past 8. Did you want to wrap up for tonight?
Oh yeah, I just wanted to remind everybody. I'll just go back to the slides. So there's the questions, and just the last slide is just thank you everyone for participating. Just a reminder that Janssen supported Cornerstones to be able to bring this to all of Asia Pacific, Australia and New Zealand. Without Janssen, this program wouldn't be possible, as I said, across Asia, Australia and New Zealand. And also thank you obviously to Cornerstones and to Joanna Howe, who's been instrumental in getting everything organised.